Welcome to Section 7 of the Acid-Base Physiology Review. In Section 7, we will walk through a Davenport diagram, a diagram often tested on the USMLE STEP exam. We will also walk through additional practice questions to test your ability to approach acid-base disorders. Welcome to Section 7 of the Acid-Base Physiology Review. In Section 7, we will go through more questions of acid-base disorders, as well as walk through a Davenport diagram, which is a commonly encountered question on the USMLE Step 1 exam. Here we have a Davenport diagram. Davenport diagrams provide a relationship between blood pH, concentration of bicarbonate, and PCO2. Let's walk through this question. In the diagram, point X indicates acid-base status of a healthy person. You can see the pH is in the normal range, the PCO2 is at the normal level, and the serum concentration of bicarbonate is also at the normal level. Which of the following is the most likely cause of the condition indicated by point Y? Let's move to point Y and see what we see. First, let's look at the pH. The pH has fallen to below the normal range. 7.4 the normal range, and the pH has fallen to approximately 7.35. Thus, this is an acidemia. Next, we look at the serum bicarbonate concentration. The serum bicarbonate concentration is elevated, approximately 34 milliequivalents per liter. Thus, the cause of the acidemia is not a metabolic acidosis. Next, we move to the PCO2. PCO2 is well above the normal range at 60 millimeters of mercury. Thus, the primary disorder is a respiratory acidosis, and there is metabolic compensation to return the pH to a near normal range. In the answer choices, which of the following would most likely represent a primary respiratory acidosis with metabolic compensation? A. Adaptation to high altitude. B. Chronic obstructive pulmonary disease. C. Diarrhea. D. Ingestion of a strong acid. Or E. Severe prolonged vomiting. B represents a scenario where one would have a primary respiratory acidosis, metabolic compensation leading to a near normal pH. Thus, chronic obstructive pulmonary disease best represents the point Y. In approaching the Davenport diagrams, I would recommend a similar approach to any other acid-base problem. First, identify the pH, whether an acidemia or alkalemia is present. Then look at the bicarbonate concentration to see if the cause is metabolic. And then look at the PCO2. If the cause is not metabolic, to see if the cause is a respiratory disorder. Let's go through a few more questions. Question 1. An anxious 17-year-old woman presents with perioral numbness and carpopedal spasm. A laboratory examination reveals decreased PCO2 and decreased bicarbonate. Which one of the following conditions is most consistent with these findings? A. Metabolic acidosis due to lactic acidosis. B. Metabolic acidosis due to diarrhea. C. Metabolic alkalosis due to thiazide diuretic use. D. Respiratory alkalosis due to hyperventilation. Or E. Respiratory acidosis due to hypoventilation. Once again, the laboratory abnormalities we have are decreased PCO2 and decreased bicarbonate. Thus, the two possibilities must be metabolic acidosis leading to respiratory compensation, or respiratory alkalosis leading to metabolic compensation. The clue in this question is the perioral numbness and paresthesias, as well as carpopedal spasm the patient is experiencing. These are all symptoms of alkalemia. Thus, while we do not have an arterial blood gas to confirm pH, we suspect this is alkalemia. With a decreased bicarbonate concentration, the cause must be a primary respiratory alkalosis due to hyperventilation. Question 2. A 60-year-old male with long-standing COPD who develops vomiting would have which of the following blood gas and electrolyte patterns? A. Sodium 138, chloride 89, bicarbonate 35, PCO2 47, pH 7.49. B. Sodium 138, chloride 105, bicarbonate 25, PCO2 38, pH 7.44. C. Sodium 139, chloride 92, bicarbonate 32, PCO2 30, pH 7.65. D. Sodium 140, chloride 95, bicarbonate 25, PCO2 40, and pH 7.42. We will review the clinical scenario to determine which would be the best answer. The question states that the patient likely has long-standing COPD, which suggests that the patient likely has a chronic respiratory acidosis. The only choice of the answers available that would suggest a chronic respiratory acidosis is A, where the PCO2 is increased. Normally, we would expect in steady state that the pH is slightly below the normal range, because compensation is never complete. However, a new acute disorder, vomiting, has developed, which has thus raised the serum bicarbonate concentration, leading to a alkalemia and a metabolic alkalosis. Question 3. The serum anion gap will increase when the plasma concentration of which of the following increases? A. Sodium, B. Potassium, C. Lactate, D. Chloride, E. Bicarbonate. Remember, the anion gap increases in the setting of acidoses, where the acid is not one of the measured anions present. In this question, the only choice that is consistent with that is lactate, C. The anion gap is the difference between the concentration of sodium and the concentration of the major plasma anions. When acid is added to the body, the free hydrogen binds the bicarbonate. The bicarbonate concentration thus falls. However, there is still the free anion that was present initially with the acid. This anion then contributes to the anion gap, increasing it. Lactic acidosis is a clinical scenario of increased anion gap. Question number 4. A nursing student presents to the emergency room with a 3-day history of severe vomiting and orthostatic hypotension. Which of the following metabolic abnormalities is she most likely to have? A. Hypokalemia, hypochloremia, and metabolic acidosis. B. Hypokalemia, hypochloremia, and metabolic alkalosis. C. Hyperkalemia, hyperchloremia, and metabolic alkalosis. D. Normal serum electrolytes and metabolic acidosis. Or E. Normal serum electrolytes and metabolic alkalosis. Once again, we return to the clinical scenario. This is an individual with signs of volume depletion, demonstrated by the orthostatic hypotension, as well as severe vomiting. Vomiting leads to acid loss, creating a metabolic alkalosis. The resulting metabolic alkalosis leads to hypokalemia and hypochloremia. Thus, the correct answer choice is B. Question number 5. The following laboratory data is obtained from a patient with diabetes mellitus. Plasma sodium 142, plasma potassium 6, plasma chloride 105, plasma bicarbonate 7, plasma glucose 620, and the arterial hydrogen 80 milliequivalents per liter. Which of the following is this patient's anion gap? Once again, the anion gap is calculated by taking the serum sodium concentration and subtracting the sum of the serum chloride and serum bicarbonate concentrations. In this setting, this would be 142 minus the sum of 105 and 7, which is 112. Thus, the anion gap is 30 milliequivalents per liter, or C. While other measured cations and anions are offered, the anion gap is routinely measured only with the sodium, chloride, and bicarbonate concentrations. Thus, the correct answer is is simply the difference between these two. In this case, this is C, 30 millikelvins per liter. This concludes Section 7 of the Acid-Base Physiology Review course. This is also the end of the Acid-Base Physiology Review.